The next speaker, or the next topic, is staying with the mitral valve theme. It's an in vivo quantification of the apical fixation forces of different mitral valve stent designs in the beating heart by Siskiska Pokorny. Welcome.
Dear Chairman, dear ladies and gentlemen, I'm very happy to be presenting our most recent experimental study here today. I have nothing to disclose. So mitral regurgitation is the second most common valvular disease and has an increasing prevalence with age. Gold standard of the treatment is a mitral valve repair or replacement requiring a cardiopulmonary bypass. However, as we just heard, many patients are non-compliant to these techniques. Therefore, current development focuses the development of a mitral valve repair or implantation technique on the beating heart using a transcatheter technique. And here we see a couple of the mitral valve stent prototypes that have been proposed in the past by different groups worldwide. So on the left, we see Endovalve, HiLife Medical, Mitrassist Medical Device, and the Valtech device. And on the right side, the prototypes proposed by CardiAQ, Neovasc, that is what we just heard in the last talk, Tendyne, and the Edwards Fortis valve. The last four have most recently been implanted in first-in-man trials, so it's a really acute topic. This is a prototype we have developed in our group in Kiel. It is comprised of an atrial element, a ventricular body containing a bioprosthetic heart valve, and an apical fixation system. The apical fixation system is again comprised of 4 individual neocords affixed to the ventricular rim and then affixed against a counterbearing on the apex of the heart. It is a self-expanding nitinol stent frame covered by a thin PTFE membrane. The focus of this study was the quantification of the apical fixation forces, so the forces that are acting upon the apex of the heart after fixation. And we believe that this is a really objective parameter that gives us information about the mechanical forces acting on the mitral valve stents, may provide a guide for positioning also during later clinical implantation, and allows a comparison of different prototype designs. Therefore, we developed a test setup that is comprised of a force sensor in the middle, connected to a computer for digital data recording, and then on the other side, the load cell is connected to the neocords of the apical fixation system. This has to allow in vivo quantification, so a simple and fast setup is required in a sterile surrounding, and of course reproducible data has to be recorded. And here we see 2 images showing the test setup in our experimental implantation, with the load cell in the middle connected to the neocords and the computer in the back on the non-sterile side. So if we look at the forces acting upon the mitral valve stent, we have the measurement forces on the apex, which are a resulting force of different force components. So surely the main component is resulting from the pressure difference between atrium and ventricle, mainly during systole, where the pressure is pushing on the closed mitral valve. But we also have a shape component resulting from mechanical properties of the valve stent, and a movement component, or a component resulting from the movement of the mitral annulus, in particularly in longitudinal direction, as well as a friction component resulting from the interaction in between stent material and the native tissue around. So to evaluate this test setup developed, we implanted a mitral valve stent in 20 pigs of the German landrace, or large white, with an average body weight of 50 kilogram, and compared 2 different fixation designs. The first group of 10 animals was implanted with a stent with sole apical fixation, and in the second group with 10 animals as well, additional sub-annular fixation elements were added to the ventricular part. We conducted force measurement after implantation, as well as a 2D and 3D echocardiographic evaluation and hemodynamic measurements. So here we see the first design with sole apical fixation, called AP. That is just the design I presented a couple of slides earlier. And in the second design, sub-annular fixation elements were included into the ventricular body, here indicated by the red triangles and seen on the lower pictures. So in the first step, the mitral valve stents were implanted in a beating heart approach. And then after successful implantation, the forces were quantified. Force measurement was conducted under TEE position control. There, the MAPSA proved to be a really important parameter for this, and of course the observation of possible PVLs. Hemodynamic control was conducted, and particularly observation of the wedge pressure, and forces were recorded under expiratory breath hold. So correct deployment and positioning was achieved in 18 of all 20 animals. 2 animals were excluded from the study due to ventricular fibrillation that occurred prior to stent implantation. Force measurement was then conducted in 18 animals, 10 in group AP and 8 in group SA. So this is the presentative slide of one force measurement of one animal, and you see how the force is increasing and decreasing throughout the heart cycles, being larger during systole and lower during diastole. If we look at the results of all animals, the blue bars indicate the results of the design with sole apical fixation, and the green bars the results of the design with additional sub-annular elements. And we are looking at the maximal forces, the minimal forces, the mean forces, as well as the amplitude being the difference between maximal and minimal forces. We observed a significant decrease of the forces in the group SA for the maximal forces, and seeing the same trend for mean and minimal forces. And for the amplitude, the difference was significant as well. So if we look at the mean forces, the forces were reduced from 3.1 Newton for the apical fixation, about 1/4 to 2.3 Newton in the sub-annular fixation group. Quickly looking at the echocardiographic results, we see that we have slightly better parameters in the group of sole apical fixation, with a normal EF and low gradients in both groups, even though the transvalvular gradients were still lower in the group with sole apical fixation for our prototypes tested in this study. So in conclusion, we can say that we achieved successful development of a test setup to quantify the in vivo forces for the first time. We compared 2 different prototypes with each other and found reduced forces in the group with additional sub-annular fixation elements, even though the echocardiographic parameters are still a little better for the group with sole apical fixation. And we believe that this is possibly an important parameter to guide the stent positioning in a clinical application as it provides an objective parameter. Would like to thank our team.
This paper is open for discussion. I think, Tommy, you had a question, right?
Well, I just had a question for one of the slides. You showed that the ejection fraction was going down. Were these animals who had a mitral incompetence beforehand?
No, those were in our porcine model, we implant into animals, really healthy animals, so they aren't suffering of.
Then I don't. If there would be mitral incompetence, I would say the ejection fraction before would be overmeasured in comparison to post. But
right.
If there's no incompetence, then I don't understand the significant decline from some 63 to 48. That's quite a decline of
That is quite a
ejection
decline, and
fraction
we are
after implant.
that is a second design with our sub-annular fixation elements. We still see some problems with that design occurring, like we had problems with stent fracture in that design. So that is what I said, that the echocardiographic results are still better for the group with sole apical fixation, but where we see the decline of ejection fraction as well directly after surgery. However, if we observe those animals for a little longer, the ejection fraction rises quite fast again. So like a couple of days after implantation, it's back to normal.
Okay.
Murali Padala from Emory University. Very nice presentation, and I have 2 questions. The first thing is that your force, one of the parameters that you did not mention is the long axis reduction of your left ventricle is going to determine quite a lot of force on the valve because it is anchored at the apex.
Yeah.
So did you see any differences? You did not present.
One more question.
Oh, of course. That is the force component I mentioned by the movement force. So as I said, like, of course, the force we measure is a resulting force of different components. And of course, the movement of the mitral annular plane, so the MAPSA, that would be the movement of the shortening and lengthening of the ventricle, does play an important role. And we're currently conducting different in vitro studies to kind of split all those forces that are acting within the heart apart from each other, because of course it's really challenging to get that in vivo. So I'm currently conducting some in vitro trials to see the exact.
And the second question is, if you just get the transvalvular pressure gradient and divide that by the area of your valve, do you think you'll just get the same force that you had spent 20 pigs in measuring?
We are actually normalizing the forces, of course, because after every PIC, every PIC has a little different hemodynamic situation after implantation. So what we did is we normalized the forces, the actual measurement forces, to normalize pressure difference in between atrium and ventricle to make them comparable.
Thank you.
Right, I would have one more question. Basically, you have mentioned that there are some devices who are already in first in main use. Your team is developing your own kind of design, and the difference is you anchor the valve at the apex, which is first thought logical, but you see all the other devices anchor the device more or less on the two leaflets with some additional kind of arms.
Yeah.
You know? And what makes you develop your direction, and are you thinking this is the way to go forward from here? Or would your team think like, okay, we may need to change our design and follow some similar kind of arm technique to kind of anchor the valve on the leaflets?
Well,
what's your thoughts on that?
Our approach is really to kind of follow both directions. That are why we're trying to develop into both directions, to see actually what different impact the different design strategies have, and to see whether one is better than the other, or well, to see what they're actually doing to the heart.
Which is good.
Yeah. Last short question, please.
Manny Subramani. I didn't see that you tested this under two different conditions, in a high flow and low flow, because as you know, the transmitral gradient goes very high on a high flow. So it may affect your force balance relationship in quite a bit. And so I would advise you to do that. And the second thing is, one quick question, is that the total Newton force in the both leaflets and papillary muscle about 6.5 or 7, even if you include the papillary muscle. So you probably ought to test to that amount of force.
Of course, well, just to quickly reply to this. So we are actually, during the force measurement, we are actually increasing the pressure a little bit to see the normal, to see different pressure levels and how the force is reacting on this. I haven't included this in the results yet because we're still evaluating the results. And the second is, of course, we only measure the apical fixation force. So a lot of force is kind of left at the annular plane, which is good, I believe. We just want to see what is actually acting on the apex, and that's why I'm conducting those in vitro studies, to kind of get those different force components apart and see what is happening where.
Great,
Thank you very much.